Good evening or good afternoon or good morning to everyone who's viewing this. We are now beginning our 2023 Orthopedic Diversity Leadership Consortium Best Practice Showcase. And as many of you may know, this is the end of our second season of transformation talks that took place every fourth Tuesday during the academic year. And as we love to share lessons learned and best practices, we're going to conclude this second season with our showcase featuring our very own ODLC members and diversity leaders of healthcare. Always want to take a pause to acknowledge the official sponsors of ODLC who really not only support the operations and the mission, but also help us achieve full circle integration of equity, inclusion, and diversity leadership by amplifying the touch points we have with medical device and the sales force. So thank you to Stryker, to Pew Synthes, True Color, and Total Joints Orthopedics. For those who may be new to the Orthopedic Diversity Leadership Consortium or may be experiencing ODLC for the first time, just to give a little summary, we collectively are a response to the exponential uptick of appointments of diversity leadership that occurred in 2020, but even in the years prior to. As a result, a network, very powerful, innovative network of healthcare equity leaders was formed, leading to us becoming a very tried and true resource for those who are either charged with being the leader, supporting the leader, or acknowledging and appointing. Started as a very small group, and now we have over 250 members. We are specialty agnostic, as the industry called for this to be relevant for all specialties, all positions in the healthcare inclusion and equity space. And last but not least, we love to network. And so this was the flyer from our very first ODLC meetup. And to believe that occurred 3 years ago, is just very, just warms our heart. And so we will be entering our fourth meetup in February of 2020. And so again, like I said, we are a pioneering network of diversity leaders brought together for the purpose of best practice and innovation strategies for success. However, the mission is clear. How can we collectively optimize effectiveness and sustainability, not just of our roles, but of the work that we do within them? And so this is a summary of our 2022 to 2023 calendar of transformation talks. Started in October of last year with reimagining strategic diversity leadership. We launched our first benchmark, a DEI leader job description. We talked about committees, myths and realities, communication strategies for the new year, and then concluded with emphasis on strategic plan development and, of course, collaborations. Do you build, buy, or borrow? And so here we are at the culminative event, our 2023 Best Practice Showcase. So our agenda for the next 45 to 50 minutes will be as follows. We'll start off with Dr. Holly Pilson from Wake Forest University Atrium Health, and she'll review a very robust departmental and enterprise strategy. Dr. Artina Dawkins, also from Wake Forest University, will talk about leadership value and how to translate interventions to scholarship. Dr. Wade McAlister will present a very novel initiative that I like to describe as resident-driven belonging. And then we'll conclude with Dr. Sharon Harrell, who will talk about establishing employee resource groups de novo. And so with that, I am going to kick it off to Dr. Holly Pilson.
Well, good evening, good morning, good afternoon, whenever you're watching this. It's a pleasure to be here with you all to share a little bit about some department strategies in however you term the work that you're doing in this space is JEDI, DEI, etc. My name is Holly Pilson, and as Dr. Taylor mentioned, I am an orthopedic trauma surgeon at Wake Forest University School of Medicine. I'm also Associate Dean for JEDI for School of Medicine, and I co-lead diversity inclusion efforts in our department with Dr. Artina Dawkins, who you will meet next. So this is a very ambitious list of some things I hope to cover in the next 10 minutes, and hopefully give you some food for thought about ways that we have been able to successfully strategize in the area of diversity inclusion within our department. And hopefully you can take some lessons and pearls from these. So the first thing I wanted to talk about is DEI leadership. So it's likely that many of you who are joining or listening to or watching this webinar at some point are here because you either are already in a diversity leadership position or you've been asked to assume a diversity leadership position in your organization or in your department, or maybe it's a future interest or a passion of yours. And so I actually really vividly remember back in probably 2018 or 2019, Dr. Taylor and I are really an hour away from each other between Duke University and Wake Forest. And I knew that she was in a leadership role in diversity inclusion in her department. And it was something that Dr. Dawkins and I had taken interest in sort of pursuing in our department. And I remember calling her and talking to her about this very thing. Like, what are you doing? How do you do it? Because at the time there was no ODLC and there weren't very many diversity focused leaders in departments across the country, and certainly not within orthopedics. And so we had a very meaningful conversation that blossomed even further to networking. And I think now we're just so fortunate that she has been able to lead us all in this organization to better strategize in this area. So in 2019, Dr. Dawkins and I were able to express interest to our department that we really wanted to lead in this space. We saw a tremendous opportunity, certainly in the field of orthopedic surgery as the least diverse specialty in medicine. And we had gained some momentum that year from an institutional wide focus on a year of inclusion. And so we were able to successfully negotiate our leadership positions in DEI within our department with our chair at the time, Dr. Komen. And we really wanted to stress the importance of, this work in diversity and inclusion is really the work of all of us, even those of us who aren't named or specific leaders. But I think it's certainly very helpful to have established leadership in this area to best strategize and make sure that we are maximizing our efforts and getting good outcomes, like we're actually achieving what we set out to achieve. And so Dr. Dawkins and I were established as co-leaders for diversity and inclusion in our department. And along with that, something that we really didn't appreciate early on, but over time we have been able to acquire is dedicated time, a budget, and a strategic plan, which I know we're going to talk a little bit about. And so I would say, even if you're already leading this space and you're watching this and you're thinking to yourself, wow, I have none of those things. I don't have dedicated time. I don't have a dedicated budget, and I don't have a plan. I think, don't fret. There's still time to develop that. And certainly when we started out, we didn't have that from the beginning, but it's something, fortunately, that we learned along the way. And now we have all of those things. And it's just so important, both from the standpoint of being able to create value in the work that you do and also value from your leadership. I also wanted to make sure that in the diversity leadership within your organizations and your departments, that you also want to make sure that you have a finger on the pulse of what's happening throughout. So at the institutional level, from the top down, what are the CEOs of your organizations or the chairs of your departments, the people who are really making the big decisions, what is their view and how do they hold the value of social impact, health equity, diversity, and inclusion as it relates to the entire organizational structure, as well as the larger organization strategic plan. So we're very fortunate to work at Atrium Health Wake Forest Baptist and Wake Forest University School of Medicine, where we understand and are charged every year from the very top of our leadership all the way down that it is an intentional strategic priority. And so that really creates an easy opportunity for us as leaders in this role to really link the things that we're doing very strategically back up the ladder to those very important strategic priorities for our organization. So I would challenge you all to sort of investigate, if you haven't already, what those strategic priorities are for your larger organization, and make sure that the work that you're doing ties in very meaningfully to that. The second area that I wanted to talk about was culture, creating a culture of inclusion and belonging. And I know some of the other speakers are going to touch on this as well. And so just to kind of give you a few ideas of some of the things that we've done in our work in our department to encourage this and cultivate this inclusive culture, is that first we decided back a few years ago that we didn't want to assume that we were aware of all of the needs of our department, and our department is pretty large. So we started by creating a needs assessment survey that we sent out to the entire department to really better gather what does our department think that we need in this space. And it was very informative for us. There were certainly some blind spots that we had that helped better inform our strategic planning for the year. And so I would encourage you, it doesn't have to be robust, but I think just getting a handle on what are the needs of your department, both from the leadership level, but also all the way down all the way down the hierarchy to figure out what are people needing that they don't have and what would they like to see more of. We also are intentional about highlighting culture, religious, and other holidays and celebration and recognition of department members who may celebrate those holidays on a monthly basis. And another way that we've been creating a culture of inclusion and belonging is by working to establish a podcast series where we pick a podcast episode and on a Jedi related topic, and we discuss it as a larger group. The other thing I wanted to stress was the importance of accountability. So many of us had departments in our organizations and institutions that created these position statements after the death of George Floyd, and I kept all of them. I screenshot them. And Dr. Dawkins and I actually helped create the position statement or the statement from our department, so we knew exactly what it said. But I wanted to make sure that we were holding ourselves accountable for the things that we said in that moment, that we were pledging to do, that we were expressing was important. And we want to make sure that we're holding ourselves accountable to that. And so it also creates an opportunity for us to build in accountability throughout the many different layers of our organization, our department. So we created some just code of ethics, professionalism documents, and expectations at the trainee level that we have them, that we go over with them every year, sort of what we expect from them, how we want to make sure that we're creating a space that everyone feels empowered and included and that they belong. And we have it sign it, and that's how we hold them accountable if something comes up. We have an anonymous unprofessional behavior reporting system that also allows people to sort of anonymously report things that happen that may not be easy to sort of navigate. We also provide active bystander training every year in our department, or upstander training that some of you may be familiar with. And then the Kennedy Hopkins Mentorship Program is actually a program that was founded and is currently directed by Dr. Dawkins, and hopefully she's going to elaborate on that. But it's a fantastic mentorship program that pairs our underrepresented in medicine residents and trainees with mentors across the institution, as well as provide some additional professional development in this space. And I just wanted to highlight a couple of podcast clubs that we have put on. And again, we want to make sure in every one of these episodes, we're bringing others in from our department who don't necessarily have a called out diversity leadership role, but we want to be inclusive and want to have others come alongside us on this journey and help us navigate some of these tough conversations. So this is just an example of a podcast that we worked through with one of our podiatry faculty on mitigating cognitive biases in patient care. There's another conversation, very meaningful conversation that we had alongside Dr. John Shields, one of our arthroplasty attendings, on the Speak Up Ortho movement. And so we listened to a She Can Fix It podcast. And we sort of had very, very tough conversations about the Speak Up Ortho movement and some of the difficult comments that have come forward from that movement. And then just another example, with one of our physical medicine and rehabilitation colleagues, we had a very interesting podcast club where we discussed physician perspectives of patients and with disability in their healthcare. So there's just a couple examples of ways that we have done that. Another opportunity, which I think that you mentioned, Dr. Harrell is going to talk about, is that there are also resources typically available at the institution level or the enterprise level. And so we're fortunate here at Atrium Health Wake Forest Baptist to have several what we call affinity groups or system resource groups that we try our best to plug in members of our department to those affinity resource groups as well. You can go to the next slide. And those are just a few of those resource groups. And so what we have recently gone through an integration, and we're still going through an integration in the Atrium Health. And so we have, which many of you probably have similar committees within your department and organizations or similar service lines. And so in our social impact committee team, we wanted to make sure, again, that we aren't sitting alone in a silo doing work that is set apart and over there that you sort of have to join in this club to do. We wanted to make sure that we're infusing a social impact and a health equity lens in all the work that we're doing. And so the work that we're doing in social impact, it covers and spans all of the committee work within our department, as well as all the other service lines and locations, so that we're making sure that we're informing and helping them in the work that they're doing to make sure that we keep and maintain an equity lens. One of the ways that we have done this, if you go to the next slide, is to create for each of those committees a social impact best practices or DEI best practices toolkit, in an attempt to sort of help them in the work that they're doing and all the different subcommittees and areas to best maximize social impact across the work that they're doing. And so there's a series of questions that we ask them to consider. And then also every year, as we are all creating and thinking about goal setting in our committees, and we're reporting up to our chair what our goals are going to be within our committees and our divisions throughout the year, we have asked them to maintain and create a SMARTY framework for their goal setting. So if you go to the next slide. So most of us are pretty familiar with the SMART framework for goal setting, in which you set goals that are specific, measurable, attainable, relevant, and time-bound. So what the SMARTY framework is that you just add an I and an E to the end of that, an I for inclusivity and an E for equitable. And so this is a very simple way to allow those in your department and your organization who maybe feel a little uncomfortable with diversity and equity and inclusion and don't really know how to achieve it or don't really know how to incorporate it into their daily work. And I think just introducing this concept of, we're not really asking you to do something new or different. We just want you to think about it in the work that you're already doing. How are you ensuring that the goals that you're setting are inclusive and equitable? Who may be left out of the conversation, or who is at risk of being marginalized by this goal that you're setting, and how do we mitigate that? And so we've been able to help strategize through our committee work and help form some very specific SMARTY goals related to the work that's ongoing. And we want to make sure also, if you go to the next slide, that we're considering what are the social determinants of health that we need to consider when designing these goals, and what is at risk of being excluded again. Realizing that 80% of our patients' health is based on those social determinants of health that are separate and outside of the healthcare, the direct healthcare that we that we provide. The next thing is I want to talk about is professional development. So I think it's very important as, you know, most of us are not, this is not our first sort of training or our first sort of area of practice. I'm an orthopedic surgeon. I don't consider myself a diversity expert. So I think it's very important that as you are placed into positions of leadership in this space, that you seek professional development. For us, we were able to budget for our professional development every year. And Dr. Dawkins and I were very happy to participate this previous year in the ODLC eCornell Diversity Certificate Program, which was very meaningful. And I would highly suggest those of you who haven't already considered it to really look into that. And that was supported, thankfully, through industry sponsorship, but also through sponsorship through our department and the budget that we had created to realize, you know, we're not experts in this. We need ongoing professional development. There's also diversity related conferences such as Movement is Life, Ruth Jackson, GLAD Society, et cetera, both in medicine and outside of medicine in the business world that you can take advantage of to continue to grow. For education and training within our department, we provide several available trainings. So we do an annual department active bystander training, which teaches how to mitigate incidences of incivility effectively. There's a safe zone in medicine training that is provided, I think, quarterly. And we also have a health equity certificate program that we participate in as faculty, that residents and students can sign up to receive a health equity certificate. It's a year-long program. Next development. So last couple of things I want to talk about is recruitment. So I think it's important, especially in a field that struggles with workforce diversity, to really develop a strategy around recruitment, both of trainees and faculty and staff. And so there are a multitude of different ways to accomplish this. There's no one right way, but I think some of the things that have worked have been participating in recruitment fairs. So SNMA, LMSA, et cetera, have recruitment fairs at their annual meetings that you can become a vendor. You can talk to potential residents and fellows for your program about your program, and that's a great recruitment way. We also have a diversity first look, which is typically virtual, and a diversity second look, where we invite applicants from underrepresented categories to hear from us as faculty as well as trainees at our program. And that is a fantastic recruitment effort. I think very importantly, I wanted to stress is that one of the things we've been doing for the past several years is making sure that every new interview committee member is trained on how to minimize bias in the interview process. And so we provide that training ourselves, and we have done so previously with our Office of Diversity and Inclusion. And I think that's very important. And then many of you may be familiar with the GLAD Society's diversity ranking by academic year. The last time they put this out was in 2021. But prior to implementing these, some of these strategies, our institution was ranked 38th on the list of diversity ranking by the GLAD Society. And then after implementing just some of these things that I talked about, we were ranked 18th. So I think just a little tweaking here and there and some implementation of these strategies can really go a long way. And then in terms of faculty recruitment, there's lots of ideas, but one of the things that have worked for us is that we typically will reach out to our talent acquisition team when we have an opening and talk to them about ways to recruit diverse faculty. And typically they work with sometimes external groups to identify diverse talent in the field that you're looking for and the subspecialty that you're looking for. And there's also opportunities to advertise for those positions through some of the organizations like the GLAD Society and the Ruth Jackson Society. And then lastly, pathway programs also are a great opportunity to showcase what you're doing in your department. And so partnering with the organizations such as the Anthem Mentions, Perry Initiative increases your ability become exposed to a wide variety of prospective applicants as well as faculty to your program. In addition, we have some internal programming through the IDEA grant from the Academy that we call Odyssey in Orthopedics, that really allows us to bring in diverse grand round speakers to interface with our department, to increase our national exposure for to come as a visiting lecturer, and then we pair that with an outreach opportunity in our local school. The last thing that I wanted to mention is that I think it's really important that we celebrate the work that we do and that we recognize those who are really champions in this area. So this is modeled very well at an institutional level in our organization, where they really do a very intentional job of recognizing and celebrating the work that is being done. And these are just some of the awards that Atrium Health has received in diversity. And then we try to do this to model the same in our department. So starting about 3 years ago in 2020, we started our first annual diversity awards. And so many of you are familiar with the He for She Award. Now it's called the Freddie Fu He for She Award for Ruthie Jackson. So every year for the past 3 years, we have an award winner in the He for She category. And we also have a department, what we call an All for Our award for a diversity champion in our department. And so at the end of the year, we celebrate these award winners at our end of the year banquet. And we really want to elevate and recognize them for the things that they're doing to help us maintain a positive culture of inclusion and belonging, diversity. And that is all I have, and I'm happy to answer any questions.
Great. Thank you, Dr. Pilson. I wish I could just give you a sound bite of applause. That was phenomenal. I'm going to just ask you a few questions. I have so many. Basically, how can I copy and paste you to my institution? But I wanted to dive deep into something that you mentioned quite frequently during your presentation, and that's the idea of social impact. And I noticed you and Dr. Dawkins have that embedded in your title as part of your purview, whereas many individuals may have culture and well-being or diversity, equity, inclusion, or something that's a bit more scoped. So tell me a little bit about what social impact means to you, to your institution, and how you were able to make that link to something that has greater than just internal department bonuses.
Yeah, that's a great question. So I think for us, honestly, I feel like social impact is a phrase or terminology that a wide variety of people and audiences can kind of get on board with, right? So I think ultimately in healthcare, our primary goal is the end user is the patient, is the society, is the community. And we all have a very shared goal to make sure that our society and our community around us is healthy and that we're being socially responsible. And I think that when we frame the work, which all the work that we're doing is directly tied to that, ultimately, many of us know that workforce diversity is tied to that, but not everybody makes that connection. And so I think it's a really good way to bridge this divide that sometimes comes up in the work that we do with people who just can't really grasp or understand why it's important for us to do certain initiatives or things, that they can't quite make the connection downstream to how that influences social impact. So I think for us, it's been a really good way to make everyone, or a larger audience, I will say, understand and relate to the importance of the work as it's tied directly to the communities that we serve and that we impact in the work that we do.
I mean, that resonates with me completely, as I'm sure it will to our audience members, because that ability to speak a different language to garner more engagement, buy-in, therefore implementation is so important. And the last question I wanted to touch on, you presented such a wide reaching strategy, and just to see the results of that, it is tremendous. You are a diversity expert, by the way. and role model in all of the above. I wanted to know if you could drill down to one or two key factors that will make your work sustainable. What are they? What will keep this engine going beyond even your use?
Right. I think that's a great question. I think when we first started this work, this very strategic work, I would say, I would argue to say even before Dr. Dawkins and I were formally in this role, we were doing some of the work already without a title, right? Which many of us are. But I think that when we started the work, we sort of felt, I think at first that there was a lot of responsibility on us. And I think it was key when we recognized that for the work to be sustainable, that we have to do a very strategic and intentional job of making sure that everyone understood that it was everyone's work and not just the DEI leaders' work. And so I think in order for the work to be sustainable, you have to figure out a way to get buy-in from members across the department, across the organization, across the scope of whomever you're leading. And you have to engage them in a way that they also find the work meaningful and that they can come alongside you and help, the heavy lift that it is to do the work. And so I think that is one pearl I would add to the sustainability. And the second one is I think that it's really difficult to do the work without support of your leadership. And support can look like a variety of things. It can look like financial support, which is certainly helpful and needed. It can look like time, so dedicated time to participate in the diversity certificate program, or dedicated time during the week in terms of FTE to focus on strategizing and building out the work, and being able to have resources available to help you, I think is another pearl to making sure that you can sustain the work long term.
Well, we applaud you and your team and your leadership for bringing all of this to fruition. Bravo! I am speechless, which is rare. So,
Well,
with
thank you. And I applaud you as well. I mean, again, seriously, you were the only one I knew that was doing this work back in 2018. And I mean, you were always available for all my questions by phone call. And I think, it's amazing that you built this fantastic consortium of many of us leaders and future leaders who are really trying to strategize in this area. So kudos to you as well.
Thank you, Dr. Pilson. That means so much coming from you. I am going to transition now to who has been mentioned multiple times this evening, the Dr. Artina Dawkins, who will present to us a specific approach she has taken to really catalyze scholarly works in this area. So, Dr. Dawkins, let me spotlight you and turn the mic over.
Awesome. Well, thank you, Dr. Taylor. And yes, Dr. Pilson and I have been in the trenches for a while doing this work together. And it's great to see just the fruit of that. And so I appreciate her presentation. So good evening, everyone. And it is a pleasure to participate in this evening's ODLC Best Practice Showcase. I want to thank Dr. Taylor for the opportunity to present in this showcase. So because of ODLC, I have this particular opportunity, so thank you. I also want to thank Alyssa for her help with the logistics of this evening's session. So the title of my presentation is DEI Leadership Best Practice, Translating Your Intervention into Scholarship. As a researcher, scholar, and practitioner in leadership, mentorship, and in DE&I understand the value of capturing your ideas in the form of publications. So a little bit about myself. I typically include a slide that talks about myself, but I totally forgot, so I'll just wing it. I am a connector. I'm an encourager. I'm a woman of faith. I grew up in the South. I'm a friend. I'm a sister. I believe in mutual respect. I'm a daughter, and that's just a few of the descriptors that I would use for myself. As far as my formal training, I have a BS in biology from Wake Forest University, a Master of Public Administration and Nonprofit Organizations from High Point University, and a PhD in Leadership Studies from North Carolina Agricultural and Technical State University. So let's proceed into my presentation. So the context that I am bringing this particular topic, it falls under three realms: organizational change, multiple mergers, and a dual pandemic. And this is the context in my particular institution and in our area that has given rise to this topic. So the first thing, organizational change. So the current environment in which I work, and Dr. Pilson mentioned this, so in which we work, is one of organizational change. According to the scholar Lewin, organizational change is the movement that an organization goes through when it goes from a known state or status quo to an unknown or planned state of being. And that is a thought that was brought forth by the scholar Hussein et al. In a 2018 article. So according to Lewin, change occurs in three phases. The first phase is unfreezing, and that's where the organization readies itself for change. People hear about the change, and there's a preparation of the state that is unknown and that is planned. The second phase is change, and that's where the changes actually happen. So in our particular scenario, this is where cultures are aligning, job descriptions may be changing, different discussions are happening, and so there's just a state of some uncertainty, but it's a state of change and flux. The final stage is refreeze, and that's where the organization reaches its desired and end state. We're not there yet, but I would say that we're definitely in that state of change and flux, where things are changing and evolving and emerging, and we receive updates, but there's so many things that are happening rapidly. So some results of the change are planned, while there are unintended good and bad consequences, which ties back to one of the courses that I took in the ODLC diversity certificate, which is healthcare change management. So it was kind of cool to see that implemented. So multiple mergers. This organizational change has been due to back-to-back mergers within our health system over the past 3 to 4 years. This change represents aligning of different environmental cultures and subcultures, standard operations, roles, and chains of command. While strategic and periodic change is often advantageous and produces opportunities, prolonged change can be disruptive and produce uncertainty. And in regards to the dual pandemic, so this environment that I have described, along with the US reckoning with racism and COVID, has given rise to an atmosphere for the emergence of leaders in diversity, equity, and inclusion, as well as new interventions. So that relates back to the advantageous nature that change can produce. So like the statement from Plato goes, our need will be the real creator, from which we get the translation, necessity is the mother of invention. Next slide. So this environment has given rise to several opportunities. This environment of constant change, multiple mergers, the COVID pandemic, and the US confronting the history of racism in this country based on the murder of Mr. George Floyd were an unexpected catalyst for the emergence of leaders within the DE&I space. Although resistance remains based on reluctance to fully acknowledge the existence of and implications of racism, even now in this country, offices of and committees of diversity and inclusion, varying in their specific names, as well as DE&I leadership roles were created or built out, including in my department of orthopedic surgery and rehabilitation, which Dr. Pilson mentioned in her presentation. Additionally, internal groups such as affinity or system groups and external groups formed, such as ODLC, the ACGME's DE&I group. The AAMC has several resources that they have created for this work. They were formed to support the success of these new leaders. And that's according to an article by Taylor et al., a 2022 article. So this environment also gives rise or gave rise to support for DE&I efforts at a level that I had never seen before, as well as new content and interventions focused on including rather than excluding based on race. So leaders are visionaries, problem solvers, capacity builders, and content creators. And this is according to an article, a 2013 article by Gator. DE&I leaders in healthcare are meeting the challenge of leading their respective areas through necessary organizational change by creating DE&I strategic plans like the one we created in our department, and priorities, providing educational content that focuses on the values of respect and equity, operating as thought leaders, creating new infrastructures and interventions to eliminate racism and all forms of incivility in the learning environment, in the clinical environment, and in research. Prior to COVID, I founded a mentorship program called Kennedy Hopkins Scholars Mentor Program. And it's a mentorship program for minoritized residents and fellows as an added layer of professional and even personal support. And this was based off of observation and an observed need. And it was launched in the same year that the institution deemed the year as the year of inclusion. And so I founded the program and was named as co-director of diversity and inclusion, along with my colleague, Dr. Pilson, giving a greater platform for me to expand my leadership experience in both GME and diversity, equity, and inclusion. As co-director, we were able to implement department-wide DE&I programming, which had not been implemented before. So these roles were inaugural, and we were appointed as the inaugural directors to lead this initiative for the department. The role of founder and director of the mentor program created an opportunity to empower residents and fellows of color through mentoring relationships and to create a curriculum containing content on racial equity in healthcare, mentorship, and elimination of health disparities. Next slide. So, scholarship. Scholarship, particularly published manuscripts and articles, because scholarship does manifest in other ways, but particularly scholarship is one of the key avenues for sharing your new DE&I interventions, processes, and procedures with your peers. This can be done by generating empirical articles or publications such as perspectives or education innovation reports. And there are even others, like if you are able to draw and you are able to image what you have created, you're able to publish that as well. And so these type of publications allow you to describe your process and detail associated outcomes. It is important for you to consider publishing articles about these new DE&I interventions, infrastructures, processes, and procedures for several reasons. There are others. This is not an exhaustive list. These are just a few. So one, the research and expertise that you utilize to create new content is your intellectual property. So why not showcase it? Two, publishing about these interventions and the associated lessons that you learned will function as a guide to peers and colleagues, as well as future DE&I leaders. And I think some researchers think that the greater value is when you publish something based on a success, but also if you publish, well, what didn't go well, that is also useful as well, because we know that things don't always go well. And so that can be, that's publishable as well. Publishing allows for a historical record of the advances in DE&I, which is particularly important in lieu of the recent SCOTUS decision, and based on historical efforts to remove historical information about racial and other inequities. So it's important for us to flood the literature and increase the body of scholarship with these types of interventions and things that we've done. Next, given that you have created a novel idea or novel ideas, you are likely to generate data that has not been published before, giving you a great opportunity to publish new knowledge in the body of literature. And finally, career advancement. Scholarship is often the currency by which people advance in their career. So this is a great way to publish on what you're already doing. And according to content that I've heard, if you have one article, you have 2 articles. It is important to do background research to ensure that your novel inventions are grounded in the literature and that you are utilizing a data-driven approach. This is particularly important because unfortunately, sometimes this work comes with resistance on multiple fronts. So the more you can make your case with data, the better. So utilizing a data-driven approach helps to not only make the case for why a focus on diversity is important, it also informs the direction that you lead your office, committee, or section in. Because sometimes the way you think you're going to start out may not be the direction that you end up going in because the data has shown something different. Central to your potential publications is documenting your interventions, your processes or procedures to inform your audience so you don't forget those nuggets, those nifty things that you did that no one else is doing, so that when it comes time to publish, you'll have it. And in DE&I work, the higher goal is to make things better for those who are coming behind us, for those who are that we're currently working with, to deconstruct these structures that are replete with racism and other mechanisms to hold certain people back. And so it's important to that we have these publications to show people how to kind of navigate through those kinds of things. So because the DE&I field was experiencing new interest and support, it is important again to publish in case that trend changes. Okay, next slide. Let's see. I think implementation. There we go. Okay. So while my primary focus of creating a DE&I intervention and best practices, again, is to solve a problem or to address a gap, I think of the ideas and concepts that I implement in terms of how could I potentially publish some aspect of it. And so you want to kind of think at the beginning, and maybe it might be too late, but in case you're embarking on maybe a new phase of what you're doing, you want to think of it in terms of, well, if I were to publish this, what would I do now? What would I capture now to make sure that when it comes time to see all this new data, this positive result, like Dr. Pilson showed, we went from, I think, 38th to 18th. I didn't realize that. So that's something that there's a lot there that can be published. And so if you start out thinking, how can I publish it? It makes it easier when you get to the actual writing process. I aim to make a note or journal what I implement, when I implement it, who I talk to, and other occurrences associated with implementation of the new ideas. And this is especially important for qualitative research, because you have to have a detailed account of your environment, who you talk to, the participants. And so if you journal along the way, it makes it easier. This takes intentionality, as it is so that it makes it easier to capture it along the way. For a phenomenological study, including a detailed description, as I said, of the research environment, the type of institution, the participants, makes it possible for a future researcher to duplicate your intervention at their institution, group, or organization. And it also helps them to see the differences between your institution and theirs, because there may be enough nuances for them to take a note and maybe make a change or tweak before they implement what you've implemented. Decide what journals and the associated audience that you think would benefit from your material, which impact factor may be a factor, but that's just something that kind of figures into publishing. Okay, next slide. Publishing a manuscript is satisfying, rewarding, and has a positive impact. You add new content to the body of literature, you could potentially be deemed as a content expert based on your writings, and you build your portfolio, which may result in career advancement and personal satisfaction. Next slide. You are or have already generated novel interventions, processes, procedures. It makes sense to write up and publish what you've already implemented to share with your audience. Be sure to cite and give credit to other scholars, whether their work is published or not. Not doing so is taking credit for someone's work, which is not demonstrating integrity. Where possible, collaborate with others, share credit. It's important to recognize the value of your own work and the effort, time, and expertise required to positively impact a culture. It's not easy to change a culture, so we need to capture this. Especially if the work that you are doing is helpful for your organization to meet accreditation or other regulatory requirements. So don't shortchange yourself. This is helping your organization and your institution. So you should capture it. It's not easy to act as a change agent while standing as a DE&I lead, leader, but we are doing it. So thank you so much for this opportunity, and I yield to Dr. Taylor.
Thank you, Dr. Dawkins. I see how you and Dr. Pilson are such a powerhouse together. I have two questions. I had some other questions, but now that I've seen and heard the detail, I'm going to shift a little bit because I need some pointers. So
Okay.
the first question I wanted to ask has to do with research and data access. So I'm curious if you've ever run into this obstacle where you have a research idea, you have an intervention for an equity, inclusion, and/or diversity scholarly topic, really need that demographic data. Need to identify disparities, whether it's related to care, representation, advancement, attrition, etc. And because of concerns around compliance or potential litigation, you are told, no, can't have it. Why do you want that data? Can you tell me a little bit if you've ever run into that and how you navigate around any resistance for uncovering the truth?
Wow, there's a lot in that question. So thank you for that question. And yes, I have run into that. It is the questions, why you want it, what are you going to do with it, which are fair questions, but it does kind of add an air of intimidation, perhaps, or trepidation, I guess I should say, like, huh. So what I've learned to do is there's more than one way to do something. And so if I'm not able to get data from a source because they are holding the data, and they are, I would try to find a way to identify another source for that information. And so, I mean, and if you can't get access to the actual demographic data, then that's just what it is. But there are other ways. You can look at websites and kind of see. There's a lot of Googling that you can do to get information. And perhaps there's another person that you could ask for this information. And it may be that you have to kind of share the intent when you don't really want to. And so I guess you have to weigh, do I want to give insight to this really good idea so that I can get this data, or am I going to just find another way to do it? And so, yeah, because
it sounds like you're drilling down on that power of partnership and collaboration and really, diversifying your resources.
And I would also say, so especially with collaborating, sometimes different collaborators have different social capital. And so you may want to consider, okay, let's say someone has more social capital with a certain group. Well, you go and ask for this particular thing and see where you get. And that person who has different social capital, different cultural capital, which is a term that I just became aware of, which is relates to Bordeaux's theory of capital, if I'm not mistaken. Part of that is cultural capital, and there are various levels, and sometimes that's based on demographic groups. So if your partner, your collaborator has different social capital, they may be able to get the data that you were not able to get. So that's something to
I
think about.
that I love that. Thank you for that answer. And the second question I had for you had to do with something you said earlier on about the different phases or levels of change. And thank you
Mhm,
for mentioning that very popularized theory and work that is applicable today.
mhm,
What would you advise our leaders who, despite their best efforts, their organization or department or company is stuck in unfreezing? And unfreezing feels good. You focus on education and you learn and you go home and you high five, but they are hesitant to take that next step into actual change. What advice
mhm.
for encouragement, words of upliftment would you give to some of our DEI leaders or chairs or company heads who are stuck in unfreezing mode?
Mm, hmm. That's a good question I haven't considered. So I think one is communication because, and especially in our organization, it is I'm not sure how many employees, maybe 150,000 or so. And so, and we have been in a state of change again for 3 to 4 years. So communication has been one of the major factors that we have been asked about. Like how do you prefer to get communication? Do you want a monthly email? Do you want a weekly email? Biweekly? We have been asked that at different points during our mergers. So it's definitely an important question, especially because of the how large our organization is and how many different groups there are. But I would say if the leaders can find a way to communicate authentically with their team, sometimes I have found that things are happening. Maybe especially in the beginning, and there was a reluctance for authenticity. And I understand that leaders, there's only so much that can be shared, but there is a level of authenticity I think that leaders need to have so that people aren't because if there's so much secrecy, then people start filling in the blanks, and then there's fear,
Yes.
and then all kind of things that could have been nipped in the bud. How had you just had a conversation with me to say, and even to say, I don't know what's going to happen. I mean, we as leaders, it's okay to say I don't know, but follow that up with, I will make sure that whatever I know and I can share, I will. I can, I'm here to talk through um, any misgivings you may have, any questions that you may have. I'll try to get answers. And, and I share in your uncertainty because there's some things that I don't know. So I think being authentic and having those
Great.
conversations as much as possible. I think we get emailed so much, but some people might prefer emails. So,
Mhm.
whatever regular communication, but I think if you can be as authentic as possible, I think that would help people to go from the unfreezing to the actual change because we're going through it together. And then hopefully the planned state, the end state, which hopefully is better.
Thank you. Thank you. I love that. I want to just share one more time Dr. Dawkins' references. Clearly, she is the researcher of the group. We appreciate you for everything and for being an open resource for so many. And I applaud your work you've done with our societies as well. And so, thank you, Dr. Dawkins. I'm
Thank
going to
you.
shift gears. Your information is here. We're going to shift gears and go outside of the state of North Carolina just for a little bit to the state of Texas. And so I'm going to highlight my new friend, though I see it feels like I've known you for years, the Dr. Wade McAlister coming to us from the University of Texas, Houston. So, Dr. McAlister, welcome. Thank you for your work, your friendship, and your courage and all that you do in the South. I appreciate it tremendously. And so I'm going to
Sure.
turn this over to you.
Very well. Yeah, thank you very much, Dr. Taylor, if I may, Erica. I had the opportunity to meet you at Chicago AAOS when you were giving a talk about the leadership roles in DEI, and I had been in my position in the department about a year at that point, and everything you were saying, it just really spoke to me. And I'll probably be reaching out to Dr. Dawkins at some point on how I can write some of this stuff up now. But I have enjoyed listening to the other talks, and I look forward to the final talk after mine. And so, actually, in point of full disclosure, this is an initiative that I kind of brought to our residency, and I think it was very helpful in getting us to kind of jumpstart the whole DEI process in our department. And Dr. Taylor was able to experience it. I will say she is the first and only so far non-UT person to have been able to experience this. So I'll get to share what we've done with the rest of y'all now. So yeah, the title of my talk is The Impact of Personal Stories on Residency Culture. And as she mentioned, I am at UT Health Houston, the McGovern Medical School's Department of Orthopedic Surgery. I serve as the chief of the orthopedic surgery service at LBJ Hospital, which is one of 2 county hospitals here in Harris County. And Harris County actually surpassed New York City as the most diverse place in the United States culturally and ethnically back in 2013. I think we kind of bounced back and forth with New York City, along the lines with the Astros and the Yankees that kind of go back and forth every year. So anyway, that's kind of the environment that we're in here. And if you go on to the next slide, the kind of like was already alluded to by the other speakers, there's a huge increase in the DEI world in 2020 and after that. At our institution, I had been on the faculty diversity committee since about 2015 or 2016, and was the chair of it the final 2 years. And then our department, at one of our curriculum meetings, was discussing establishing a DEI curriculum, as well as having some kind of a DEI focus within the department. So I approached the department leadership, mentioned that I had been at the university level involved with the DEI initiatives, and volunteered basically my services to help out with the department. And we formed the orthopedic DEI panel. We decided to use the term panel instead of committee or some other thing, because we didn't want to sound like we were going to be some kind of like a regulatory agency coming after and penalizing people and being the cops coming around the corner. So we were an inclusive group with residents and faculty. That's what we started as. And from my role on the faculty diversity committee, we had actually been given the role of oversight of the institution's DEI strategic plan. And so we were in the second year of that when I was rotating off of that committee. So I was very well versed with what the institution as a whole was going for. And so I brought that knowledge to our department. And one of those things was, how do you discuss DEI topics, and how can you get it introduced and involved with or integrated into the curriculum? And we also wanted to have it be homegrown as opposed to given to us either by the institution or by an outside agency such as the ABOS or some other organization. So in January 2021, we were establishing a DEI curriculum for the orthopedic residency, and wanted to figure out a way we could do this but still have open dialogue. So if you go to the next slide, that was kind of our opportunity, was how could we introduce the DEI into the curriculum, have these complex, sometimes controversial and potentially painful discussions, but have it be able to encourage an open discussion. And going back to my role as the chair of the faculty diversity committee, the first few years on that committee, we were meeting like monthly or every other month, depending on the academic year. And we would spend a lot of time to the hour just kind of sitting around a table looking at each other. Somebody would make a comment and then nobody else would say anything. And so when I became the chair of that committee, I wanted to have and encourage more open dialogue and discussion. So I came up with the idea of personal stories and basically, kind of an expanded self-introduction, and would have each of the committee members kind of give a talk about themselves. And after introducing that, we had a lot more open discussions. We were able to have, the work coming out of the committee was really expanded. And I think we had a big impact at the institution, because we had members of there were 21 members on our committee, and they represented probably 12 different departments around the institution. So we were able to have a wide reach with that. So I brought that to our department with the personal stories, so that we could have the residents who all came from different backgrounds, be able to have open discussions and not feel pressured to think or say certain things, or avoid speaking about certain topics. So next slide, please. So this just refers to my prior implementation. So this is kind of the context that I had. And if you go to the next slide, talk about more of kind of like what these were. So I kind of, I don't know if it's a trademark violation, but we basically used the TED Talk as a kind of a springboard. And I introduced this to the residents as this is basically a TED Talk about yourself. So the session will be an hour, but you're not expected to speak for an hour. You can get a lot of information in a 10 or 15-minute presentation and leave the rest of the time for open questions and discussion. This was opened up to volunteers. Nobody was assigned it. It wasn't like the PGY4s must do this, or whoever's on this certain service. If you're on my service at LBJ, you have to be the one to present. I opened it up to volunteers, and when discussing the different topics, I said, just kind of think about what makes you you. We're all unique. We're all individuals. Some of us have multi-heritage backgrounds. Some people have lived all over the place. There's all different sorts of different things, so different experiences you may have had. You may have played professional or collegiate level sports. You may have been like an academic decathlon. There's all different things that you may have done, or you may have overcome some huge obstacle. But it's kind of what do you want us to know that we may not have known about you? And so again, it could be any aspect. And as one of the residents found out, food is never wrong. He brought some homemade Lebanese food, and it was a big kick because these sessions are in the morning. So it was a nice little breakfast for everybody. Go on to the next slide, please. So some of the things we were also considering, because there was some hesitancy at first when I brought this up to our program director and our vice chair for education. And so because this was 2021, we were still kind of in the realm of WebEx and Zoom meetings and doing some conferences in person, kind of depending on the level of COVID. So I think we had just opened up to in-person conferences, but we had these restricted. And basically it was like a closed door meeting. It was during the regular academic conference time for our residents. So at our institution, that's Thursday mornings from 7 to 10. We embedded the DEI curriculum as like a grand rounds with 3 hours dedicated to it. And one of the hours was set aside for the personal stories. It was restricted because I wanted to have the residents feel relaxed and open. And although I hate using the word safe space, I did want to create a safe space, for the residents to be able to have open discussions about, potentially difficult topics, and also make themselves, be able to become vulnerable and share things about themselves. But so that was kind of our discussion, and having an open access with Zoom and WebEx, we also restricted that. So there's a special link that was sent out by our program manager to people in the department, and it was not shareable. Also, if we had visiting students, they were allowed, so they were allowed to attend as well. And then something else that became evident at the first talk was you needed to have a roving mic, especially for the folks who are on WebEx, because they couldn't hear the questions being asked during the discussion session. So I ended up serving as MC, and would get a couple of microphones and have two people kind of running around, to take the questions, to make sure that the people that watching remotely were able to hear everything that's going on and be able to participate more in the discussion. And then like that, since it was virtual, did we want to record it? We did end up recording these. There was a lot of discussion going on about that as well, because as a public institution, a state university, there's a lot of behind the scenes things that have to happen if you're recording things. And actually, the law has changed in Texas now. So if we're on any kind of Zoom, WebEx, Teams, any other kind of virtual meeting, there has to be a disclaimer at the beginning that it is being recorded. If anybody objects to it being recorded, you have to stop the recording, and somebody can take minutes, but they can't be digitally recorded. And then something else was where to put it in the curriculum. And meeting with our vice chair of our education program, we decided to have this scattered. We have a 2-year curriculum. I'm not sure what other residencies have, but we have a 2-year curriculum, And there are 5 dedicated grand round sessions that are 3 hours each, dedicated to DEI topics. And one of those hours is reserved for the personal stories. And then also we're kind of his go-to group if they have a last minute cancellation. So I kind of have a list of volunteers who've volunteered to give their personal stories, and with a few weeks or months notice, somebody else drops out of the regular curriculum conference schedule, we kind of get plugged in. And if for some reason we can't do that, then we make it into a journal club. But so DEI becomes kind of like our default if somebody cancels in the curriculum. So next slide. And so I do believe in leading by example. And so on the faculty diversity committee, as well as in our department, I gave the first talk. And going back to the faculty diversity committee, since we were meeting monthly and we were going to have monthly personal stories, I tried to tie it into whatever the official month was. So Native American Heritage Month, Hispanic Heritage Month, Black History Month, Women's History Month, that kind of thing. I tried to tie it into that, and again, it wasn't mandatory, but I kind of tried to use that as a jumping off point for people to kind of volunteer. And so a lot of people don't realize that I am of mixed heritage and Cherokee on my father's side, and so our first talk happened to be in November, which is American Indian History Month. So I went first and talked about my Native American heritage and also what the Cherokee Nation is all about, and kind of our history going through from pre-European contact all the way up through the present day. And I have a couple of example slides here. And so I am a citizen of the Cherokee Nation, and I'm able to be that because of direct genealogical line back to my great grandmother, who was on the Dawes rolls in the 1890s. She and my grandfather, who's in the middle picture, were both born in the Cherokee Nation, which was part of Indian Territory before the state of Oklahoma became a state. My father, who's on the right-hand side, was born in Oklahoma. But so it's just like any other citizenship, it passes down, through heredity. So I am a Cherokee Nation citizen. I vote in our elections. I actually hold an advisory role to our chief on different topics. So that's kind of where we jumped off from. I gave the first talk. I reached out. I did kind of volunteer one of our DEI panel members, who was one of the resident members, that I'd appreciate if she would be the first resident to go. And then after that, we had like just the floodgates opened with people, volunteering, both faculty and residents. Next slide. So to date, we've had 13 stories. This is since January 2021. 9 residents have presented, 3 faculty, 1 visiting professor. That happened to be my cousin, who is also a Cherokee Nation citizen. She is a total joint surgeon in Tahlequah and Muskogee, Oklahoma, and she was one of only 2 orthopedic surgeons within the Cherokee Nation. So she was having her practice there. So I had her come down just to kind of give the residents an idea of what it's like to practice in a very rural area with a high Native population, and kind of what her experience has been like. She's an amazing woman. She actually went to medical school after having raised a family and after having worked in banking. She was an intern when one of her daughters was in sorority rush. So just imagine, going through your life going through residency at that stage in your life. She wanted to do a fellowship in joint replacement, and went back to northeastern Oklahoma and has practiced there for the past, I guess, 12 or 13 years now. But on the next slide, I think I have a list of the different topics and themes that have been covered. And the topics and themes are as varied as the individuals, obviously. So one of our residents, and this is the one that Dr. Taylor was present for, is Navajo. So we actually have 2 Native Americans in our department, which is extremely rare. We're the least represented ethnic group within medicine, let alone orthopedics. And being, I'm male, she's female, so she's even more rare than anybody else. So Navajo, Cherokee, Lebanon, Ghana, Barbados, Holland, Venezuela, Taiwan, Iran, India. There's others that I'm probably forgetting where people's heritage came from, and all the different aspects. Some of these people were born in these countries and immigrated as young children. Others are first generation in the United States. Just kind of the different struggles and things that they had going through when they were growing up, and then also family and personal side of things. Like Some people either they had addiction within their family, they had family members in prison, immigration issues, homelessness, academic struggles, abandonment by their parents, language issues growing up, especially so a couple of our residents did not speak English and as their birth language. They grew up speaking something else and then learned English later on. Faith was important to several people as well, and also impacted how different people kind of experience life. One thing that was very uniform, even with those who had abandonment, did have family support, and then also just the different family makeup. You can imagine people coming from other countries. They may have multi-generations in one household that may have been raised by grandparents while their parents were off working 2 and 3 jobs. So all different aspects of things. And so based on all of this, if you go on to the next slide, that really opened up. A lot of the residents became very vulnerable. They shared a lot of very personal things. To a person, when a resident either volunteered or when I would reach out to somebody saying, hey, some other residents would like to hear your story, to a person, they said, I have nothing special to talk about. And at the end of the talks, everybody was just blown away. The co-residents were blown away. The faculty were blown away. I'm actually getting emotional now. Some residents would cry, giving their presentations, just talking about some of the different things. One of our graduating chiefs a couple of years ago said, or after that first, he graduated this past year, said it was the significant improvement in camaraderie. We had a good, strong culture within the residency, but he said there was a significant improvement in the camaraderie among the residents, and they had developed the strongest team feeling he had felt since he had been a collegiate football player. And here's a picture of the residents actually enjoying a day in our clinic at LBJ. They must have found out that a case got canceled, got to go home early or something. But so there's been a lot of camaraderie, a lot of support amongst the residents. And if you go on to the next slide, it's been very eye-opening for everybody. This has led to complete buy-in by the program director, the vice chair. We were given a permanent slot in the curriculum because that was kind of like a trial that first 6 months. So we've been given that permanent slot. And like I said, the DEI aspect of the education is in a grand round setting. So we'll usually have some type of a guest speaker about a certain topic, then do a journal club, and then have a personal story, usually in that order, but it kind of varies based on the people's schedules. But that's kind of what we do. We've only had the one person bring the food. He's been reaching out to others to bring food and trying to shame them into doing it. So we're looking forward to some good stuff, I think, coming up this year. Next slide, please. So just basically the simple act of sharing and people making themselves vulnerable, being very personal in their stories and exposing different aspects of their life that the co-residents are unaware of, has led to a lot of empathy, a lot of feeling of inclusion and understanding. We were able to have really difficult discussions and topic about different difficult topics because we would choose things during journal club that touched all aspects. It wasn't just workforce things in the DEI literature, but also the disparities that exist with certain groups in receiving care, as well as the different social determinants of health, and just the impact of just the social determinants of basically residency success. How do you navigate family planning, that kind of stuff, and just kind of the discussions around that. I was kind of shocked by some of the comments that were made by some of the residents, but again, this was meant to be a place where we said everything's going to be said from a place of wanting to have better understanding of each other. So if somebody asks what you think is an offensive question, don't be offended by it. Just understand that the person asking it truly just wants to understand. And so, go with that. So this did lead to a lot of deeper discussions on difficult topics, and I think improved and deeper respect amongst the whole team. Next slide. And this is a memorial photograph, including the first time somebody outside of UT was brought in to hear a discussion. And the presentation that day was given by Dr. Miley Kerbo, who is the resident standing right behind Dr. Taylor. So that's kind of the end of my talk. I'm open to any questions you may have.
Oh my goodness, Dr. McAlister. Thank you so much. I remember, I will always remember having the privilege of hearing that story and being a visitor in your space. And I mean, the impact you so nicely articulated is just crazy how vulnerable you're able to create in that space. I want to talk a little bit about these. I know we don't want to say safe spaces, but I think you've created brave spaces. I've heard that
Right.
terminology before.
That's a good term. They start using that.
Yeah, I think that's what you're describing. One of the things in your slide that you mentioned that has really struck a chord with me is empathy. And we talk to leaders, we talk about the inclusion space, about the need for empathy to create respect and belonging. Not many people understand what that word means, or they use it in the wrong way. I wanted to just ask you to go a little deeper on that part of this experience, which is the creation of empathy, and how have you seen that even impact the clinical care spaces from this initiative?
Yeah, sure. So like I can think of a couple of examples actually where people mention something, you can see like light bulbs go off in the audience's heads. And so one was when we were discussing actually pregnancy during residency. And this is actually during one of the journal club settings. But so again, everybody felt more comfortable speaking about these types of topics. And we're about 25, maybe 30% female residents right now. And we've had several of our male residents have had their wives have given birth during residency, and their wives have actually been residents in other areas. And so they actually understood kind of what their wives were going through. But there were some comments made by some of the male co-residents saying, well, the pregnancy affects the male resident just as much. You have to miss residence, you have to miss different things, because of helping your spouse or your wife, whatever, as well as doctor's visits and stuff. I said, and the female residents were like, look, you don't have to have this bowling ball in your abdomen for 9 months and have to worry about lead and in the OR and pee breaks and like all these different aspects that they just hadn't considered. They kind of were
Right.
they understood like the 9 months and the doctor's visits and the odd hours and being there for their wife or girlfriend as they're going through this, but it wasn't the same. And being able to have that discussion. One of the faculty that gave a talk, he's African American, and was talking about how some of his patients are very, very surprised to see that he's Black, and this is coming from Black patients, and that some of them appreciate it, but also some of them are kind of still questioning, are you a real doctor? And then he also talked about he trained in the Northeast, and relayed stories about when he was a resident and going through the hospital and being talked to as if he was one of the cleaning crew, not a doctor, even though he was clearly in scrubs and clearly in a white coat. People just assumed he was part of the cleaning crew. So that was like another, a point where people just hadn't even considered that, that could even happen in 2020, 2018, 2015, whatever that was. So that's an example.
No, I appreciate that. You sharing so candidly, and I'm curious what you see as the future of this initiative. Do you see this continuing on in perpetuity? How have you been able to ensure the sustainability for this?
Yeah, I'm hoping it continues on. Again, I've had a lot of people come to me and say, these talks are amazing, and then they're like, I don't want to talk because I have nothing to say. And I try to really tease out different aspects of their personal selves to try to say, look, you have an important story. You have no idea what kind of impact you may have on somebody else, or what you may learn about yourself when you give these talks. Because
Right.
a lot of the folks have given some kind of a talk about their background or their family, and so they've reached out to their parents, aunts, uncles, grandparents to get family photos, or start asking them like, what was it like when you were growing up, or the ones who immigrated, what did you have to go through? And they really learned a lot about themselves and their family and where they came from, and kind of had a deeper understanding about themselves even. So I'm trying to make sure they get that. And then also on the DEI panel, and we can go into that discussion here in a minute if you like, about that is non-existence now. But
Ah,
we've as we try to have a couple of residents on there, and as they mature and rotate off because they graduate, we try to make sure we bring in some junior members, either interns, second years, so they can continue on throughout the residency. That we always have new people coming on. So,
well, thank you, Dr. McAlister, for everything. I look forward to hopefully being back in Houston some point in the future.
yeah.
It was amazing, and that empathy, belonging, the brave space, I felt that is very palpable there. So, thank you again for sharing tonight. I am going to bring on our closer, our C-suite member of the Best Practice Showcase in ODLC, Chief Diversity Officer, Dr. Sharon Harrell. And so here we are. The microphone is yours. And I just want to point out before you begin that, I mean, this has been just such an amazing display of the diversity of leadership scope, styles, perspectives. I mean, this is beautiful. And so I am looking forward to Dr. Harrell showing us how to create a space when you may not necessarily be in that space. And so without further ado, Dr. Sharon Harrell.
Well, thank you, Dr. Taylor, for that introduction. One of the things I like to say is that I'm thrilled to be a part of the ODLC Best Practice Showcase. And one of the things that I absolutely love about DEI is that all of the leaders are so willing to share your wisdom, to be a mentor, and just to inspire. And so, Dr. Taylor, you're an inspiration. And I want to also say thank you to Dr. Dawkins. When I was just starting this journey, I was able to reach out to her. I was very green behind the ears. Is that the right terminology? And she shared her wisdom. So just want to start off by saying thank you to both of you. And to give you a little bit about my background, I'm a 3-time UNC Chapel Hill graduate. And also I'm honored to be a fellow in the Academy of General Dentistry, in the International College of Dentists, and in the Academy of Dentistry International. And so thrilled to be able to be a certified diversity executive through the Society of Diversity and through the diversity movement. My background is in dentistry. I want to start off by saying that for the past 25 years, I've been and continue to be the dental director for FirstHealth Dental Care, where we take care of underserved kids birth to 21. And that has been my passion, creating access to care. Just like Dr. McAlister, in early 2021, I took on the additional duties of Chief Diversity Officer for our organization. And just like many of you, there were many firsts. We did our first inclusion survey. Well, let me start off by saying that at FirstHealth, we had never had anything in the area of DEI. So we did our first inclusion survey, our first listening tours, our first unconscious bias training for our leaders, our first inclusion group, and as I'm talking now, our first Veterans Employee Resource Group. And an employee resource group is really a group of employees with shared characteristics, and they can comprise any type of dimension of diversity. And they're most effective and sustainable when the Veterans Employees Group's goals align with the business goals of the organization. And some people will say, well, how do veterans fall under DEI? Well, as we know, diversity has to do with unique experiences, unique characteristics, and certainly our veterans have had unique experiences. So I want to talk a little bit about launching this group as a non-veteran. So to tell you a little bit about FirstHealth, we are a not-for-profit hospital. We have 4 hospitals. We have primary care, urgent care, hospice, and dental care. We're located in what's called the Sand Hills of North Carolina. For those of you who are familiar, probably an hour and a half south of Durham, and maybe an hour and a half sort of south east of Winston-Salem. And we happen to be about 45 minutes from a major Army base, Fort Liberty, which formerly was Fort Bragg. And so there have been, over the years, an increasing influx of military families, and they have not necessarily settled in the in Fort Bragg or Fayetteville, but many of them have settled in the Southern Pines area, which is where FirstHealth of the Carolinas is located, actually in Pinehurst. So, and also due to the proximity of the military base, we have a huge number of our providers who are retired from the military, and then they come to work for our organization. So that's the backdrop with which the Veterans Resource Group came about. And so the opportunity is just like other healthcare organizations. FirstHealth is suffering from a shortage of nurses, x-ray techs, many other hard to fill positions. And then you have veterans in the area who have the skill set and leadership background to excel in the healthcare field. And what we found in talking with veterans is that they never really thought about the non-healthcare roles that they could play in an organization like ours. And so we wanted to make them aware of those. And so our employee resource group demonstrates FirstHealth's commitment. We want to be a veteran-friendly workplace by incorporating what I call the 3 R's. And we all know about the 3 R's of reading, writing, arithmetic. But these 3 R's are recruitment, retention, and resources. And again, always making sure that your employee resource groups align with the business goals of the organization. I think all of us know that recruitment, retention, and resources are part of the major backdrop of any organization. The considerations. So we have a philanthropic arm of our organization called the Foundation of FirstHealth, which has strong community ties. We have a lot of community philanthropy. And so that group was starting a veterans recognition group. So it was actually an ideal time to initiate the internal veterans employee group with the idea that those 2 groups would collaborate. And as I mentioned before, having an employee resource group, it provides a pipeline for recruitment, improved engagement, and retention of existing veterans. It also fosters an inclusive environment for veterans. And I'll go show you on the next slide sort of how the collaboration began. Well, maybe not quite. I want to let you know that one of the key parts of a employer resource group is your executive sponsor. And we were fortunate in that we had a well-known and well-respected executive sponsor who's an Army veteran and a physician. He's on the executive team. So just like I believe it was Dr. Dawkins was saying, sometimes if you have someone in that space already, and he was in that space as a physician, as an executive, and as an Army veteran, and he was supportive. So having him automatically drove a lot of buy-in from the very beginning. Also, we used several people from FirstHealth who were part of the external group, helping the external group. We used those same persons for our internal employee resource group. So we already had sort of automatic buy-in. And the executive sponsor's role is really to champion the Veterans Resource Group throughout the organization, escalate any concerns to administration. So what's been the impact? So let me back up and say one other thing. And this is something I'll say for all DEI leaders. Everything that many of us have done are first. Like I said, the First Inclusion Council, First Inclusion Survey. And so what I would say to DEI leaders is don't be afraid to be the first. Do your research, talk to other leaders, get your buy-in and go for it. So we went for it, and we had our first Veterans Town Hall meeting very recently, June 23rd. And we think about 200 veterans in our organization that we know of. And that's another challenge is now only recently have we been asking employees to identify as veterans. So we have veterans in the past who didn't self-identify because there was not a way for them to do that. And my goal was to have at least 10% of those 200 sign up for the first town hall meeting. And we did have 20. You can see the group there. And we had our second meeting this evening, about 4 o'clock this afternoon, and we have already doubled to 40 from just June to September. And then for the first time ever, we'll have our Veterans Day event honoring FirstHealth veterans. It'll be the first time in our organization's history that we've ever done anything to actually celebrate veterans. And the veterans are very excited about that. Also, we had a veteran survey, which you can see on the QR scan code. And we asked 2 questions. We asked, what impact can FirstHealth have on veteran employees, veteran patients, and veterans in the community, and how can we expand the veteran community, expand veterans at FirstHealth. And most of the answers focused on patients. So now we are trying to, within Epic, be able to have patients indicate whether they are veterans or not, whether they go to the clinic, whether they're inpatient. And so that's one of the projects that one of our team leaders is working on, is incorporating that as a part of Epic. So we might be able to use a wristband to denote a veteran patient, or a flag outside their room. The other thing that came out of the survey was for military spouses, could we do something for those spouses? And so we have a set of volunteers who do a lot of stuffed animals. So now they're doing stuffed animals with the camouflage to give out to military spouses who give birth. So the learning points, and it's funny because afterwards I saw that my first bullet was the same as the last one, but that's okay, because that's the most important part of the slide, is that authenticity, if not part of the group. We've often heard the terminology or the saying, people don't care how much you know until they know how much you care. And so as a non-veteran, there was a little bit of hesitancy, I think, because I'm not a veteran. And actually, someone asked me, they said, well, how can you have so much passion for this? We're not even a veteran. And it all has to do with what we do every day. We care for every segment of our population. And so why would I not be passionate about trying to recognize a group who has done so much for our country? Why would I not? But authenticity takes it. You have to be authentic. You have to have authenticity, but also it takes time for others to trust that you really do have their best interest at heart. The second part was that it's called an employer resource group, but this group, we had a planning committee. They didn't like that name. So I had to roll with the punches and take out employer resource group, because they wanted to be called the Veterans Corps to better reflect their association with the military. Right now, we're still, I won't use the word debating, I'll use the word having open conversations about whether only veterans will be allowed in the Veterans Corps. The plus of having non-veterans is that you have have a connection with the broader organization. For example, if you have a person from human resources, they can bring, help some of those goals be accomplished. Myself, I'm not a veteran, but serving on the executive team, I'm able to bring those concerns to the administrative council. So that's still being discussed right now. I think the biggest lesson for me as a leader is that throughout my career, I've always drafted something and shared it for feedback. That's just how I've operated. Well, I learned quickly that that doesn't work in this group, that co-creation, I mean co-creation from the ground up, is critical. And so that was a leadership lesson for me, is really being able to not be so, I won't use the word possessive, I'll just say be willing to co-create from the very beginning throughout all parts of the process. And then the last lesson I learned is that the group wasn't really that, they didn't really, they favored more hearing internal input, even though I had talked to ERG leaders from throughout multiple organizations. That was all well and good, but really what they wanted was to really have internal input. And so I think the real lesson is really going with the flow and adopting or acclimating to whatever group that you're working with. So I guess I would say thank you. Do you have any questions? And I know, Dr. Taylor, you will.
You know it, Dr. Harrell. Thank you so very much for sharing that. I think, one of the points you touched on was not just authenticity, but also the importance of the executive sponsor. And I would love to just hear more about what qualities an executive sponsor should have Because we're seeing these ERGs maybe not be created with more frequency, but being visible more. Names are changing. We have one at my institution called Blacktivate, and it's becoming more creative and more attractive and therefore more visible. We see our med device companies having ERG, conferences, and it's exciting. I'm curious though, when we talk about executive sponsors, how would a newly formed ERG or even the idea of one pick the right sponsor?
So first of all, I would say to pick someone who's well known and well respected throughout
Mm.
the organization. That's the first thing. And secondly of all, our executive sponsor speaks up for the Veterans Core Group when we're in our admin council meetings, when we're in our executive meetings. He promotes it throughout the organization. Some of the roles of the executive sponsor are that they ensure strategic alignment with business objectives, they address key issues to actively overcome obstacles, and they communicate the value of belonging to this group to department heads. For example, if you have frontline staff who want to come to the Veterans Corps meeting, you have to be able to show the value of that to their department head or their director, who may not want to let them have a little time to come to that meeting. We need you to be here in place. And so that's been very important in that he's communicated that not only at the executive level, but at our director level, so that directors are aware. And we've had great participation, not just from those in supervisory positions, but some of our frontline staff have been able to participate as well because of his advocacy.
I love it. It actually goes to something Dr. Pilson said in her talk about having that protection, that time to really truly engage and not do it as perhaps we used to do in 2018 at midnight and on the weekends and trying to do this balancing act. And I love the 3 R's. That third one, resources. That's always going to be something that we will continue to strategize about how to gain the appropriate resources to do this work well. I want to ask you just one more question, and it's
Okay.
more of a personal, professional question. I want to just really give acknowledgement to your role as a chief diversity officer for an organization. That is not something to be taken lightly. And so, if you could just spend a minute or two just talking about going from dental practice, the Academy of Everything Dental, serving the children, to being appointed as the first C-suite diversity officer, what was most surprising to you?
What was the most surprising? Um, I don't know if it was so much surprising, but so I've spent my whole life trying to level the playing ground for kids who had not had access to dental care like many others. And so I see the chief diversity role in a similar aspect of leveling the playing ground for those who in the past haven't had a voice. But just like Dr. McAlister stated, and many of you, if you look at personal stories, there are so many who haven't had a voice, and we assume that yes, they have, but until you talk to them and learn that personal story, I mean, throughout all our dimensions of diversity, there are people who need to have a voice. And so it's been the thrill of a lifetime, but you're right, you never sleep because I still have the dental director role. And the only way that I have been able to navigate is to try to, even though you can't really compartmentalize, I've just tried to carve out specified time for the different roles, even though they overlap, to sort of just kind of, and the second piece of advice I would say is that when you first start in a role like this, you're trying to do a million things. People are asking you to do this, that, and the other, that in order to keep your sanity and not get burned out, you have to set priorities and realize that you can't do everything that people are asking. You have to set those priorities, and that'll help you be able to actually accomplish some of the goals that you set.
Well, thank you for that. I am going to close us out for what I think has been an amazing session. Of all of the panelists, I want to just let you all know that we see you. You are making a difference. I am hopeful that through the lessons learned from all 4 of our presenters, you saw yourself in their shoes too.